Welcome all. I'm Kathy Brown of Brown Nose Social Media, and today I have a healthcare hangout that I'm really excited to dive into. We're going to be talking about healthcare in an e-patient era. And today I have guest Casey Quinlan with me, and Casey Quinlan is also known as Mighty Casey on Twitter. If you follow her on Twitter, she's a hoot. And she's a national speaker, she's an e-patient advocate, and she's a highly disruptive woman in healthcare. So I would like to introduce you to Casey. Casey, say hello.
Hello, everyone. Nice to see you, or at least virtually, and also to see your lovely face, Kathy. We talk frequently, so yay, and here we're doing it in public.
And those of you who did not know her or have not known her until now, you'll notice that she has a giant QR code.
And yes, it's real. It's real. What this does, and there's a password underneath it, so it's convenient. That password is conveniently hidden by my lower third. But I mean, and I really don't care. It's not like there's anything really proprietary in there. But I have written for years that I would gladly get a barcode tattooed on my neck if it meant I never had to fill out another health history form. And then late last year, that transitioned into, wow, I could do a QR code. I mean, it's really a political statement about the lack of health information exchange for patients in healthcare. So rather than wait for the system to deliver it to me, I rolled my own. This goes to a page on my site with the password that has my health history and my advance directive. And it's a conversation starter. Everybody should have their own health data, and if their system isn't giving it to them, make their own, because then at least they know the whole picture.
Well, that was a really good summary of your personality, Casey, because that really does give them an idea of who you are. She tattooed her chest. Well, let's get right into, for those people who might not be familiar with the term e-patient, can you explain what e-patient relates to?
Well, e-patients are those of us who are educated, empowered, enabled, engaged, to use one of the buzz phrases in healthcare now, patient engagement. E-patients are already engaged. We find it somewhat humorous that the system has suddenly decided that patient engagement is really important, and it is, and we welcome that. And thank you guys for waking up and recognizing that we're here. But e-patients are the people who tend to be very proactive on their own behalf and on the behalf of their families and those they care for. E-patients can be parents of children who have challenging medical issues. E-patients can be caregivers for elderly parents. It doesn't necessarily have to be about you, and actually my e-patient journey started when I observed my parents managing their own complex conditions as they aged. My father had Parkinson's and my mother had a relatively rare and interesting aftermath pituitary tumor that the surgical revision of it gave her an interesting remaining 23 years of her life. But observing them advocating on their own behalf, and then as they aged, advocating for them in partnership with them, and then managing their care through end of life. When I ended up with a cancer diagnosis a couple days before Christmas in '07, I knew it was the universe telling me I was supposed to be shifting my attention to healthcare. It was like, okay, I finally got the message, but please don't do anything else. And so far, so good.
So what does the E of e-patient stand for?
Engaged, empowered, enabled, equipped, educated. It doesn't have to do with electronic, although if you consult the Wikipedia page, it will say something about digital and electronic. I argue with that Wikipedia page frequently, but they always remove my edits. Anyway, I mean, yes. I mean, e-patients will tend to be digital, but the thing is, in 2014, who is not digital? People are paying with their phones in Kenya with M-Pesa. To try to say that this is all, like a special population and it's only the early adopters. Honey, that ship sailed 7, 8, 10 years ago. We're all here. Healthcare is only just now, as an industry, is only really just waking up to the power of the internet to connect with their customers, who are patients, or people commonly called patients. So I welcome all of the interaction that is now starting to rise on healthcare, from the healthcare industry online. And I think that equipped, enabled, engaged, educated patients, e-patients, can be perfect partners for the healthcare system to figure out how to transform itself.
Well, I'm glad that you defined the E as engaged as opposed to electronic, because that was a confusion that I had when I first heard the term. I thought it meant patients who were electronically engaged, and it really is just engaged in general. And I think part of the reason we confuse that with being electronic is that people do go to the internet for their health information because that's where the vast majority of it is available and quickly accessible. And even the older generation is now going out on the internet, and they're actually one of the fastest growing demographics using the internet for healthcare.
Full disclosure, I'm perilously close to that particular demographic myself.
You and me both, and I'm going to refuse that AARP card when it comes.
Oh, I use the senior thing when yeah, it's like, honey, I'm over 60. I use the senior thing to get into cheap movies. Wouldn't you?
But the last study that I heard, and this is recently, said that 72%, I think it was 72% of people in the U.S. go on the internet to find some form of health information when they're trying to find something about them or their loved ones.
And here's the opportunity for healthcare, for the system, is to participate in those discussions and drive down the, to put it politely, woo-woo factor that rises up on, say, you know, Dr. Oz's thing. I am not a fan of that particular line of thinking. I think that evidence-based medicine is awesome, but unfortunately it does take, and there's a link that Kathy will share on the page about it takes 17 years on average for a scientific discovery to actually be deployed in clinical practice. 17 years. And I think that healthcare as an industry, and as a practice, does itself a disservice by not using some of the digital tools and the partnerships that they could to deploy scientific-based discoveries on new treatments, what's real and what's not, whether or not coffee bean extract today, because I read the journals, New England Journal of Medicine just confirmed again, or announced a study that confirmed again that niacin does nothing for heart patients on statins. Adding niacin will not do anything good and could do harm. So staying up to date, that's difficult for doctors. And it's also difficult for patients. But if we work together, we can help each other be more knowledgeable and help spread health literacy, which is really the bedrock of this. Everybody, both, you know, doctors need to be up to date on the science. Patients need to bring science in to discuss with their doctors if they discover it. And it needs to be healthcare needs to be a conversation.
Well, and I just shared the link that you were mentioning, that the ePatient Dave's 17-year theory. So if anybody would like to,
he's got a lot of links in that post. It's not just his opinion. And Dave's a really good source to follow for vetted real information on the ePatient side.
And there really is a powerful ePatient community, isn't there?
Yeah, there is. You know, peer-to-peer. You know, within conditions, let's say, there's a really huge multiple sclerosis community. Breast cancer social media, #BCSM, is one of the most powerful chats on Twitter, and it's also a big community on Facebook and just on the net. You know, if you want to find condition-related communities online, you can go to Simplur, SYMPLUR.com, and they, you know, dive into their healthcare hashtag project. Pack a lunch, you'll be there for a while. But the overarching group that I belong to, that I find the most useful because it has everybody from, you know, everybody into the pool. It has doctors, researchers, scientists, patients. It has everything, is the Society for Participatory Medicine. That's participatorymedicine.org, #S4PM, or e-patients.net. That's the blog. So you can check that out. I am a member, full disclosure, but it's, you know, it's a volunteer organization. By mentioning them, I don't get a referral fee. So, but I'm passionately committed to the work they do. So I would say that'd be a great place to dive in if a doctor or a patient wanted to.
Yeah, I don't have that link readily available, but maybe you can.
I will share that with you in chat over here, away from everything else. And but that's that would be one place to start. And then also, you know, Simplur is a great way to dive in. There's a lot of communities around healthcare leadership. There is you know, a lot of medical specialty groups that have tweet chats. There's lung cancer social media, which I think is happening. Yeah, that's tonight. #LCSM, which I monitor that. just because I have a lot of friends who are in that community. But every condition has, pretty much has a hashtag, or they should, and a lot of medical societies do as well.
We have a question, if you don't mind. We have a question from Scott Scowcroft, and he would like to know, on a scale from 1 to 10, how e-patient enlightened are typical hospital doctors, nurses, administrators? Any difference between urban and rural? Rural, sorry.
Rural, yes, that's like nuclear. Sometimes it can be a challenge. Well, that it's hard to quantify that, or to just parse that as I would say that rural patients are challenged largely due to connectivity issues, not due to a desire for knowledge. But because I have friends who are farmers who live out on the edge, I know that broadband access is a deep challenge in any area outside metro. So anybody who lives in a metropolitan area has the ability to learn online. And I think that some of it is, again, it's an access issue in the United States. I know that broadband access can be pricey. If somebody's on a limited income, they may end up having to go to a library. But the library, libraries exist to, and they do have internet connectivity. I know that some of my farmer buddies go to the local community college a few times a week to access actual broadband. They do stuff on their smartphones, but if they want to really do a deep dive in broadband, they go to the local community college. But the bottom line is, it really comes down to the perception, I think, is that healthcare is something that happens over there to sick people. It doesn't happen to me until I have a thing. But it could be much more proactive on behalf of the individual and their community and their family, etc., if they just dabbled a bit in understanding and learning about science and the latest medical news. Sites like the Incidental Economist. There's a whole bunch of stuff that I shared with Kathy that she'll be putting up on the event page. But there are a lot of places where you can go. It's entertaining information. It's not like, oh my God, I have to read that journal article. I do read journal articles, but not everybody's that geeky. But I'd say that everybody welcomes the idea to communicate, and I think if you look at it that way, if you look at it as a communication engine and a way to start a conversation that could be useful to you and to the other people involved in the conversation, it becomes as much fun as getting together with friends on Facebook. And it can be as instructive to all involved.
Well, and it's certainly nice to find people that can relate to your health issues. So in that way, that's a way that you can bond with someone very quickly, and that's why these e-patient resources grow, because they talk to each other, they share the good times and the bad times and the tricks and the failures and everything. Yes. And sometimes
that didn't, here's a new study. I mean, the fact that there are large communities of us out there mean that there are some of us who are reading journal articles, and we are, forgive me, I'm about to have my dust allergy coughing fit. Hopefully it'll be short, but we need to work together. I mean, doctors are not, it's unreasonable to think that we will go to a doctor and they will fix us, or there will be a magic pill that will take care of whatever. I mean, if you smoke 2 packs a day, that's going to have an outcome. If you sit around on your couch all the time and you're in love with pizza and Hardee's burgers, that's going to have an outcome. But if you take just some reasonable steps to engage and learn about what you could do for yourself, and to put together a clinical team that supports you in how you want to live your life and where you want to go, that's all you have to do. And then after that, whatever happens, you've already got a base, and you can build on that if you need help with something like, say, cancer, having been in that position.
Now, I don't want this to become a doctor bashing.
Oh no, never.
No. I'm gonna ask a question, because I'm married to a physician, but I am not in the medical field. So I think of myself as the patient perspective, but I very much familiar with the physician end of it. And this is not coming from my husband, but a lot of people that I encounter along the way, that when I talk about getting out there and getting information for patients to find, and really providing those resources for patients and building those communities and engaging with those patients and being in partnership with patients, a lot of times the answer I get is, we don't want to give that information to patients because they wouldn't know what to do with it. They wouldn't be able to understand it. They're going to misunderstand it. They're going to do something they shouldn't do because they can't understand it. And it's very frustrating to me as a patient to hear that and be discredited before I'm even given a chance to learn. What can you say to that in very nice terms?
Well, no, I will, because I do welcome a partnership, and I even welcome the idea that I could have a discussion with a doctor who felt that way and tell them that they probably don't know it, but this is already happening in their practice. There may be a digital nurse in their practice who is like communicating, like not on Facebook, but who's communicating with patients, who's giving them extra information that's going to help them deal with their thing, whatever it is. And I think that doctors should recognize that it's not all on them. They're part of a team, which does include the patient. But even if they're not quite at the door of the room that says patients are equal partners, maybe they're not there yet, but they can look at their team inside their practice, the nurses, the PAs, it could be a nutritionist, could be, but there are resources within their practice that they can use to help involve and engage patients. And if they ask their team to say, hey, are there any tools you know about that might help us with the fact that we have a bunch of patients who don't seem to get that they need to do X? I mean, it could be anything. But, rather than label a group of patients non-compliant, how useful would it be to open a conversation to find out why? It could be because they can't afford meds. That's a big problem. So have a conversation. Be open to a conversation. Nobody has to do anything, and I'm not pointing a finger at anybody. Just open a conversation. Ask a question. Who's a patient you get along with really well? Who's somebody that you always have a really good rapport with? Have a conversation with them during an office visit and say, hey, would there be something that I could show you, or, like, what would you find helpful? What have you found helpful? Why, how are you doing so well? I mean, have the conversation. Make it a communication and a discussion and a partnership.
And some of those conversations are already taking place in the communities where patients are going. It's a matter of the healthcare professionals going into those spaces and taking time to listen, right?
Right, and they are welcome in any venue that they, I would really, really advise against getting into deep conversations on Twitter and Facebook. Please don't do that. I mean, yes, you can, practices can use both those tools to great, with great results, but more about community education, offering resources. Here are 5 tips for keeping your kids healthy during the summer. Here are 2 things you can do to, whatever. I mean, you're an expert on a lot of stuff. So share your expertise, share your science knowledge, but don't diagnose anybody on Facebook. But it's a way, and please don't. I mean, nobody does. But I mentioned earlier that the breast cancer social media community, BCSM, hashtag BCSM, one of their founding members is a breast surgeon. She is the president-elect of the American Society of Breast Surgeons. So to think that there are no doctors out there or that you can't figure out how to do this, there are plenty of leaders in the healthcare doctor community, in the doctor community. Howard Lux, anyway, find him. He's one of the founders of Simplor.
That's Howard J. Lux, right?
Howard J. H.J. Lux, H.J. Lux, MD. Anyway, he's
one of the consultants. He's not one of the co-founders. I believe the co-founders are Thomas Lee and Alden Utangan.
Well, he's on their board along with some other people. But Howard has been on Twitter forever. I think he's been on Twitter longer than I have. But and he's got a terrific blog. He's done videos, instructive. He's an orthopedic surgeon, so he knows a lot about hips and knees and whatever. I mean, he's a great guy to follow for a lot of reasons. But there are a lot of doctors out there. Matt, oh God, I can't remember. Matt Katz. Matt Katz is an oncologist, radiation oncologist. And he's been on Twitter forever, Subatomic Doc. He's awesome. But there are a lot of medical professionals out there who are doing it right. And if you want to start playing, having conversations that are useful, just follow one of them and see what they do, and you're good to go.
And I also think it's important to stress that there is no one right place to do this either. Twitter might be right for certain information. Google Plus Community might be right for another. And private forums might be right for others. And that leads me into bringing in another guest that I have today, because I think that it's time to bring her into this conversation, and that is Sheila Strover. She's a retired medical practitioner, an entrepreneur, and an early adopter of social media, and she resides in the UK. Her history of social media and e-patients goes way back to the late 1990s, when she created a forum for patients to get information on knee issues, and she intended for it to be for the medical profession, but it actually ended up growing because of the e-patient base much more quickly. And I'd like to bring her in now and have her say hello. Sheila, would you like to say hello?
Yeah, thank you, Kathy. That's a very nice introduction. Thank you very much. I came into the knee world not as a knee surgeon, not as a knee expert, not as a person who had knee patients. I had the occasional one. I was an anesthesiologist. But because I left anesthesiology and became a part of my ex-husband's team of knee surgeons, I learned a great deal about the whole knee surgery world from the point of view of, I had a knee problem. I was married to a knee surgeon. The clinic we worked in was only dealing with knees. We educated people in knees. So I decided very early on to, I realized that patients at that stage, I know we're not doctor bashing, but patients at that stage in 1997 were in many cases the recipients of the more junior doctors practicing keyhole surgery, because the more senior doctors hadn't learnt it. And that created a whole wave at that particular time of secondary problems with patients' knees. And so I became, very, very much a patient advocate at that stage. But at the same time, I realized that there was a training problem, that the senior surgeons were, the older surgeons, the chiefs of the department, were reluctant to learn arthroscopy. Many places didn't have the equipment, but where the equipment was there, it was very often the more avant-garde young surgeons who would do, a quick training course, and then they would be the one who went into the patient's knees. So I did set up a forum that asked for involvement from doctors, physios, patients, the trade, and only the patients responded. And at that stage, in the knee world, there were quite a lot of angry patients as well. But the way I started involving education and doctors more, initially it was patients talking to patients. And then I noticed that they would be having an almighty argument about something where they were all wrong, because they hadn't read the literature, they didn't understand the issue. So then I realized I had to start writing articles to go alongside the bulletin board and say, look, refer to that article, and I've put some references there. So I started becoming not a bulletin board owner, but an educator, and yet I wasn't an expert. So after a short while, I decided, no, I must go to the experts and say, look, this is what I've put up for you, but in fact, Dr. A and Dr. B are the world experts. Let me ask them if they'll write a paper. So little by little, the educational content started to build, but it wasn't my primary intent. But now there's many, many pages of educational content from medical experts, surgeon experts. So that's my story.
And your forum continues to grow on a regular basis, right, Sheila?
Yeah, it's pretty much self-sustaining. I dip in and out of it, but the patients who are there, some of them have been there for 10 years. Many of them have had their issue resolved, but they have read all these educational articles. They've looked at the journals. They've become enlightened, empowered, and they stay around to teach the ones who are coming in. So so I only dip in if I'm flagged something, if there's an issue that requires a decision. But in terms of education, they just do it all themselves. Yeah.
And if I'm not mistaken, you also shared with me that those patients share the names of physicians that they're happy with, right? They kind of recommend people?
Yeah, I have a little bit of an issue there because, of course, very often an angry patient looks for a bulletin board to start being derogatory about the surgeon that they're unhappy with. And I won't tolerate that at all. I allow them to say, I have this problem. I went to this hospital and I saw this doctor and I wasn't happy with my treatment. And that's where it's got to stop. But, when they start saying he's the worst surgeon ever, don't go there, I put myself in a very dangerous position in terms of libel. And I think it's wrong. I think there's always a reason why something went wrong. But I do allow them to say, I went to this hospital and I saw an amazing surgeon, and this is his name. And I often get criticized for allowing positive things as if I'm supporting the doctors against the patients. But I think I'm just protecting everybody, really.
Mm-hmm.
Yeah.
Well, there's a question that I want to pose, and it kind of relates to a question that Scott Scowcroft posted recently. And I know his question is specifically about the U.S. and asking if the Affordable Care Act is good news or bad news for the e-patient movement. But it goes beyond that. What is happening today that's good for the e-patient movement? Is it ACA? Is it something else? So I'd like to hear from both of you.
Yeah, well, are you all right to talk, Casey? She's having.
Yeah, no, I'm all right. I've been having my dust thing, but you go first. I'll back clean up.
Sheila, go ahead.
The Affordable Care Act, of course, doesn't touch us here in the UK. We have a universal health care here, so I think that really is a question for you two on the other side of the pond. So. But when it comes
to e-patients, if you're not putting borders, what one thing can you think of that has been a positive movement forward for e-patients in the last several years?
I think the recognition by e-patients that content requires curation. So I have patients saying to one another, no, what you're just quoting, the article you're quoting, is written by a journalist. Read instead the articles that the journalist read, and they're giving the references. So they are becoming content curators as well as people who own bulletin boards like me. So they're becoming more discerning.
And Casey is shaking her head yes.
No, I mean curated content and knowing how to parse what's truth and what's fluff or fiction is critical. And successful communities will always be looking for truth, and they will listening to how the community Sheila runs her community for the knee folks tells me that she knows exactly how to do this, and that she'd be a great example, because you can't let misinformation run rampant. Now, as far as the ACA goes, full disclosure, I was uninsured after I completed cancer treatment, so I welcomed the access to insurance, because as long as we're going to have insurance to fully access the healthcare system in the United States, which that's the same as Switzerland and Singapore. We're not weird, but being able to afford insurance is important. I was priced out of the market. They wanted, I think, somewhere close to $2,000 to a little over $2,000 a month from me after I finished cancer treatment, and that's just not possible with my budget. So I went, as I say, naked. So that's one of the reasons that I'm an expert on healthcare costs too, is I know how to find out what something costs before I purchase it in healthcare. But I think that the ACA is a step in the right direction. The first year is always going to be a mess. I will confess that even though I have a lot of experience buying insurance, I bought essentially I bought a pig in a poke, and it turned out to be a dead pig. The coverage that I bought was not, it's not costing me a lot, but it's not great coverage. And even though I was a sophisticated buyer of insurance, I knew it was kind of it was a Hail Mary play. It's like, well, I'm going to try this and see how it works. And this particular one didn't. So I worry a little bit about the general population who might not be experts in insurance and parsing policies. I think that there's more education that could happen there, and it's a program that I'm looking to build with a business partner to help people figure out how to be an e-patient. And because there's so much content already available, we're just going to pull it together and present it and say here. And she's an insurance expert too, so she'll be able to weigh in on how to parse in insurance purchases. But it's an ongoing education process, and health literacy is so important, and literacy in all of these areas is important, whether you live where, health literacy is important no matter where you live. If you live in a country where an insurance market is a requirement to get access to care, then you need to know how to be literate in that, a literate consumer. There's plenty of websites out there on how to buy a car and how to buy home insurance or how to buy a house. And I think that usefully that there can be an aggregation of content for people who want to become health literate, because the information's already there. And that's why I think SPM is a good organization to join if you're interested either in learning or in teaching, because most of the great content that I found from fellow members of SPM. And then when I find great stuff, I take it to them. So it's a community education project. We all need to work together on this.
Well, I'd like to take the conversation now to the next level of using the web for health, and that is, we're talking about the Affordable Care Act, we're talking about how you pay for that insurance, how you pay for health care in general. What happens when none of those options are available to you? You don't have the money. There are some interesting things that patients are using, including crowdfunding. Can we get into that and talk about how that's being used?
Sure. Well, on the just a patient side, like say Jane Doe or John Doe out there has been diagnosed with something horrible, whatever, and their insurance is terrible, or their child has, because this is even more, even more of a problem for parents. But you've got a terrible diagnosis, your insurance doesn't really cover what you need, or you've discovered a trial, but you're going to have to throw in, there's going to be expenses around the trial, and your insurance isn't going to cover it, and because of the informed consent thing, if it's something, anyway, there's travel expenses. So you can go out on any of the crowdfunding sites, from Kickstarter, Indiegogo, which is one that I particularly like, and this is on the personal side. You can go out and ask, for community help with your, for your medical costs through a crowdfunding site. Now, if you are in the medical world, or if you want to bring a product or a service or an app or an idea, or you want to fund a new project, there is a terrific medicine, health and medicine industry only crowdfunding platform called MedStarter. Now, full disclosure, the guy who owns and runs it is a friend of mine, but that's not why I think it's terrific. Even if I didn't know Alex, I know that this thing works. Now, say you want to build an app and you want to hire somebody, and you have all the ideas and you know who you want to hire and you know it's going to cost $5,000. Then you can go out and try to raise that $5,000 on MedStarter and build your app. There are projects that Fred Trotter has done 2 really good crowdfunds on there and been successful around data acquisition and data sharing. And I know that David Harlow, Health Blog, has done a few. There's all, medstarter.com, medstartr.com, and I know that Kathy has put that link on the resources, on the event page. But I think that for those of you out there, say you're a maker nurse and you have an idea for a new device that will help all the patients that you work with do something, and you just want to get some seed funds so that you can, build a prototype and start shopping this around. Hey, go to MedStarter, raise some money, and you can even do a tax deductible thing. Because they have 1 or 2 501c3 partners, MedStarter does, one of which is Cancer 101, and if it passes their test for we can support this, they're a nonprofit partner, then you will give up a little bit of the ultimate raise to the nonprofit, but all of your all of your donors will be able to deduct their contribution.
So Sheila, have you experienced any of this with patients in the UK? Do they ever use a crowdfunding sort of approach?
My first introduction to it was from a link that Scott put up yesterday about MedStarter, and I watched the video. It's down the bottom of the comment stream if anybody wants to find it. And I was just amazed, and of course I recognized 2 of my online colleagues there in Scott and Roxanne, who's a great advocate for epilepsy. I think you've had her on your program as well. So it gave me some really good ideas. I had no idea it existed. I'm living in a little bubble that's slowly popping. you guys know so much more than I do.
You can learn anything. You have the internet. You can know it all.
You have to meet the right people first. Yeah.
We only have so much time real estate. We can't know everything. That's why we have hangouts like this to put all of this information. We have three people's lifetime experiences that we're putting into this one conversation and trying to share all the links that we can. And by the way, Sheila, if you would share your link to your forum on the event page when we're done here so that people can follow to your forum, I think that would be useful. But this is how we're trying to bring this information to people more quickly, is to consolidate that knowledge base and get it out there more quickly. Well, and that's another thing that we're starting to see now with patients is conversations where patients are actually to have a live, they're having live conversations with the healthcare providers. Like Dr. Jay Harness is doing the Breast Cancer Answers. And if you had asked a physician 2 years ago, would you engage with a patient live and answer questions, they'd say, heck no. But it's happening now, and it's happening in a patient privacy safe environment. You just have to watch how you answer a question, and that it's not patient specific, it's disease specific. So there are all kinds of things. I got off the topic there for a minute, but
well, let me raise an issue that popped into my head. Full disclosure, and one thing that wasn't in my intro, I am still a journalist, and I still practice it monthly in healthcare. I'm on the hospital medicine beat. I produce podcasts for the Society of Hospital Medicine, and I will say that just because I asked, and just because hospital doctors are incredibly smart guys. And gals, I kicked off a podcast around the voice of the patient, and based on the experience there and the some of the people that were involved at the hospital medicine annual meeting next year, on the faculty will be some young adult and juvenile, pediatric patients who will be talking about the voice of the patient, particularly in young adult and peds transitions. So bit by bit, we're showing up in places that you never would have thought we'd show up. Patients are everywhere. Good grief.
So now we're getting toward the end of our hangout time here, so I want to pose the question. We've talked about what is working well and where e-patients are finding resources, but where are the holes? What can we do better, whether it's on a patient end or it's on a healthcare provider end? What needs improvement? Casey, I'm going to let you take it away first.
Well, everything that needs to be improved, and the list is so long I won't even start, but every area that needs improvement, the one thing that would fix it is open conversation across the silos. In other words, don't just talk to your people, talk across the chasm. Doctors talk to patients. Patients talk to researchers. Researchers talk to patients and doctors. Everybody needs to get out of their bubble and go talk to the other guys. Because as long as we continue to do that, and that's not going to happen overnight, but we're just going to keep it going. As long as we all talk to each other, this ship will turn. It's not going to be instantaneous, and it might not be pretty in parts. But we will transform the system. We just have to keep talking.
Okay, and Sheila, how about you? If you were to be able to wave the magic wand.
Where the Kathy's? Are you there, Kathy?
Yes. Can you hear me?
I thought you had frozen.
Oh.
You were just being very still.
So if you could wave a magic wand, Sheila, and make one thing, improve one thing, change one thing to make the patient-physician health experience better, what would it be?
I don't know one thing. I know all the little things that I want to do, but one single thing.
Well, how about some of the little things? Go ahead and share those with us.
I think to have the physicians involved on something like Google Plus, where you can see them, talk to them, but not have a direct patient face-to-face communication, but some kind of intermediary, so that questions are screened and then brought forward by a third party, so that the patients can see that the doctors are making a big effort to engage. I know there are some that are engaged really well, but in general, I think that would be the thing that I would really like to see. But it requires, at least for the people that I'm involved with, it requires a curation of the patient's questions so that there's not a direct patient-doctor relationship construed online. So.
Well, and that makes me think of something that already exists. I'm going to throw this out there. When it comes to Hangouts on Air, there is an app. It's the Q&A app, the question and answers app. And if I'm not mistaken, if you have a large enough audience, you could ask people to post a question only after reviewing the questions, and they can vote on the questions that they would like to rise to the top. And if a question has multiple votes, that question could then be answered. And if I'm not mistaken, if I'm not a legal professional here, but if that question was clearly indicated to be a question that multiple people wanted to have answered, that would bring it into a generality as opposed to having it answered as it relates to one specific person. Not that that's good enough, but that's a good start. If anybody,
that's the sort of thing. Yeah.
As long as you keep it condition specific and not patient specific, then I think I think you're good. But as soon as a patient asks a question about, well, doc, I got this pain, so.
Okay, well, we are about ready to wrap it up here. We have so much information, a lot of the links I shared on the event page, and I hope both of you will continue to share links and that we can continue this conversation on the event page, and maybe we can pick up where we left off with a future conversation. I have one last thing that I know is going to want Casey to light up before we go, so I've been saving this for last. We talked about the need to have more patient inclusion so that patients can give more feedback and physicians and pharmaceuticals can get that feedback from patients. And the one comment you said to me, Casey, I'd like you to elaborate on, is that the difference when a conference has physician attendees and speakers and they wonder why patients don't come, a lot of it has to do with the financial ability, that a lot of those physicians are going and it's paid for, but patients, it comes out of their pocket. Can you speak to that and tell us what would it take to get more patients to be a part of those conversations?
Well, first, the invitation. I think that I'm aware of the fact that doctors and other clinicians have budgets that they can tap, but they also have to. It has to be CME. I understand that there's a lot of rules. But patients who want to contribute to the system don't have an expense account. And I think that's one of the, the MedStarter campaign that's sputtering along out there. It was my first, sort of attempt at my own MedStarter campaign. But one of my projects is dedicated to creating a cadre of citizen scientists, which includes sending patients, expert patients, not just random bozos, but expert patients to medical conferences involving stuff that they're experts in. I mean, somebody who's got Parkinson's disease has a lot to tell a neurology conference. And somebody who's had the kind of cancer that those oncologists are looking at, could make a contribution. And I think that there's a lot of science brain going on in the patient community that isn't tapped yet because patients aren't showing up at conferences. So I would just like to throw it out there to medical societies that are planning conferences. Think about including some patients on your faculty for presentations. Just think about it. There's a lot of us out here. You got questions? Ask me on Twitter, @MightyCasey.
Well, and I'd like to add as we conclude that it would also be interesting to see how many patients might be willing to use the crowdfunding to raise the funds to go to these conferences.
I've seen a lot of people do stuff for Medicine X or for whatever, or to put together a team to go and do a poster presentation at Pick the Society. And but I mean, obviously we don't want to show up unwelcome, but I think that if we do show up, we will be welcome, and if we can make contributions, that will make us and all of our colleagues more welcome, and that'll keep that conversation I'm so hot on going.
Wonderful wrap-up, Casey, and so that is a perfect opportunity for me to say that this is the end of our conversation on the healthcare in the e-patient era. Casey Quinlan, thank you for being my guest and for sharing all of your wonderful expertise and your lovely face and tattoo. And Sheila Strober, thank you for joining us and sharing your long time
Great
history.
to meet you, Sheila.
Yes,
Thank you,
it was a wonderful conversation with you both. And this concludes today's healthcare hangout, talking about e-patients. And have a wonderful rest of the week, all.
Adios.
Bye.